name is is MW. She's 55 years old. She's a 55-year-old female. She's a businesswoman from Nyeri. She's married and has been admitted for 3 weeks as a referral from Nyeri Provincial Hospital. So she presented with abdominal swelling for a period of 4 months, yellowness of the eyes, and general body itchiness for a period of 1 year. The patient was admitted 2 weeks ago while on follow-up at surgical outpatient clinic at KNH, where she was referred from Nyeri Provincial Hospital after a diagnosis of cholangiocarcinoma 7 months ago. She presented with abdominal swelling in the epigastric region and right upper quadrant pain of the abdomen. The swelling was associated with severe abdominal pain. The pain was in the epigastric region. It was sudden onset sharp pain that was non-radiating. It was slightly elevated by analgesics. The pain was constant and more severe at night. It was aggravated by eating and movement. The pain was very severe. She graded it at 8 out of 10 on onset. This was about 1 year ago. The patient fell over at work and was rushed to a nearby clinic. It has persisted since onset and is currently graded at 6 out of 10. The pain was associated with abdominal distension. The patient complained of abdominal distension that developed 1 year ago. The distension was of gradual onset, was aggravated by eating. She had no constipation, no melanal stools, no rectal bleeding. She had no nausea, no vomiting, and no hematemesis. She also presented with loss of appetite. She reported a weight loss of 33 kgs during the period of her illness. She developed rashes and itchiness on her body about 1 year ago. This began in the arms and thighs and spread to the rest of her body. The itchiness was constant. It was associated with yellowing of the eyes, pale stool, and dark urine. The patient has a 5-year history of alcohol consumption. She has no history of cigarette smoking, did not use any other drugs, and no history of contraceptive use. She has not complained of fever or chills, no previous contact with people with yellowing of the eyes, no previous history of hepatitis. She has no history of blood transfusion, no history of bruising or excessive bleeding, has not recently been managed for malaria. The patient did not come from an area with a large body of water or river. The patient did not eat grain stored in a damp area. The patient complains of intermittent bilateral lower limb swelling. She described the swelling as non-tender up to the level of the knee joint. It was worse after prolonged standing and walking. It's associated with bilateral lower limb weakness. She's currently on paracetamol, cetirizine, and vitamin K. I think just a day ago she was taken to theater. This imaging was done at Kenyatta National Hospital. Of course, I'll need help explaining the imaging. So it's an MRI of the abdomen with MRCP, and it majorly shows markedly dilated intrahepatic ducts with para-aortic nodes, multiple intrahepatic masses, and ascites, and cholangiocarcinoma metastasis. So in her past medical history, this is her index admission. She has one previous surgery, which was a bilateral tubal ligation in 1997. It was a day surgery. She has no history of blood transfusion. She has a known allergy to sulfur-based medication, no other chronic illnesses. In her obstetric history, she has 4 children, 3 daughters and a son, delivered via SVD, underwent tubal ligation in 1997, and last normal menstrual period was 15 years ago. She did not remember her menarche. She lives in Nyeri with her grandchildren. She's separated from her husband, 3 daughters alive and well, 1 son deceased at 14 years through an accident. She has 3 siblings, 1 alive and well, 1 died in a quarry, and 1 died in road traffic accidents. The parents died when she was very young, and she has an active NHIF. In the review of systems, neuro, she had no dizziness, confusion, no tremors, and no loss of balance or coordination, no visual disturbances, no history of loss of consciousness, no memory loss, or no hearing loss. In her due review, no blood in urine, no pain with urination, no abnormal discharge, no pelvic pain, no nighttime urination. Respiratory review, no chest pain, no cough, no difficulty of breathing, and no shortness of breath. CVS, no difficulty breathing at night, no difficulty breathing when lying down, no fainting or palpitations. In summary, my patient is a 55-year-old female from Nyeri, admitted 3 weeks ago while on follow-up at a surgical outpatient clinic for cholangiocarcinoma with abdominal pain for a period of 4 months, generalized body itchiness and yellowing of the eyes for a period of 1 year. Okay. In her general exam, I found a middle-aged, sick-looking female patient lying supine in bed, not in any apparent respiratory distress or discomfort. She appeared obviously wasted. She had scars on her abdomen, upper arms, and legs, a cannula on the right arm, urinary catheter with dark brown urine, surgical drain in the right upper quadrant containing greenish fluid. Her vitals were 70 beats per minute, regular pulse. Blood pressure was 95/71 millimeters of mercury. Her temperature was at 6.7 degrees Celsius. Respiratory rate was 18 breaths per minute and SpO2 of 95. The patient had scleral jaundice, bilateral pedal edema up to the level of the knee joint, grade 2. No lingual pallor, no central cyanosis or peripheral cyanosis. She had a capillary refill of less than 2 seconds. No lymphadenopathy, no dehydration, and no finger clubbing. In her abdominal exam, the patient's abdomen is distended globally, moves with respiration, with visible scratch marks, no distended veins and an inverted navel. In superficial palpation, there is tenderness in the hypogastric, right hypochondriac, epigastric, and umbilical regions, solid mass in the right hypochondriac and right umbilical regions. The mass has a smooth surface, is firm, tender, non-pulsatile, and we cannot go above the mass. She had no guarding. Deep palpation, she presented with hepatomegaly. The surface was firm with mild tenderness, smooth surface, regular edges, measured 22 centimeters by 28 centimeters. She had no splenomegaly, positive fluid thrill. Bowel sounds are present per minute. Hepatomegaly, on percussion, she had a tympanic abdomen with dullness in the right hypochondriac region, hypogastric region, and the right lumbar region with shifting dullness. Okay.
Before we go to the next session, I forgot to let Doc introduce himself really quickly. So I'm really sorry. I'm going to let Doc introduce himself and then we can go to the discussion of the case. Karibu, Doc.
Hello. Jamal.
We can hear you. We can't hear you too well. I don't know what the issue is. Could you come closer to your microphone, perhaps?
I'm Jamal Mohammed, General Surgeon from the County Referral Hospital. Are you hearing me?
Yes, we can hear you.
Right. That's, before I joined a bit in the middle, I think I saw most of the history.
Okay, do we continue to the discussion? Is there any part you'd like him to go over again?
Yeah, I think we can continue with first we finish with the presentation and then we can discuss holistically the approach in terms of either the benign causes of obstructive jaundice or the malignant causes. So we can see in history what really came out showing this is malignant and how to differentiate it as benign just from history, and later we'll go to examination, then the investigations. I think that will be a better approach, in my opinion.
I don't know if the issue is with me, but I really cannot hear you very well.
I'm saying, sorry.
Yes, continue.
I'm saying let him finish the history first.
Okay.
Then we are going to discuss what came out from history that was pointing towards a malignant cause of obstructive jaundice, and what was supposed case of benign, what will have come out of an obstructive jaundice, and what really supports this to be obstructive. I think we will dissect that at the end of the presentation.
Okay. I think so I'll let Basi Faisal continue with the next part of the presentation.
Okay. Okay, are we ready? Just start?
Yes.
Okay, thank you. Okay, we'll start with an introduction into jaundice, especially obstructive jaundice. Prehepatic jaundice is normally caused, we divide jaundice into three. We have prehepatic, hepatic, and post-hepatic jaundice. So prehepatic is mostly associated with other blood problems and issues that do not arise from the liver. So we have spherocytosis, sickle cell anemia, thalassemias, G6PD deficiency, and malaria. Hepatocellular jaundice is associated with hepatitis, alcoholic liver disease, drug-induced hepatotoxicity, Gilbert syndrome, and Crigler-Najjar syndrome. So this is a classification of hepatic that shows the different characteristics. So for example, in prehepatic jaundice, we'll have hemolysis is mostly associated with blood disorders. Serum bilirubin is high and it's mostly conjugated bilirubin. And then we have absent urine bilirubin. Urine bilirubinogen is increased. Prothrombin time is normal. And it's mostly caused by hemolytic anemia. Hepatic jaundice is caused by dysfunction in the cells of in hepatocytes. So you have deficient uptake, conjugation, excretion by hepatocytes. The serum bilirubin that's increased is mostly unconjugated and conjugated. So we have urine bilirubin present, urine urobilinogen can be present or absent. Prothrombin time is affected. It's caused by hepatitis and other issues we'll see ahead. Obstructive jaundice is just due to obstruction of the biliary, the flow of bile. So mostly conjugated bilirubin. We have bilirubin in urine, urobilinogen is present. Prothrombin time is also affected, and this will be because of the vitamin K deficiency and all that. It's caused by gallstones. We'll have other causes up ahead. Post-hepatic jaundice is our topic today. So we have obstruction of bile flow through the biliary tract. This causes the direct bilirubin regurgitation into the blood, and it's then excreted into urine. Increased bile salts in blood and decreased in the intestine. Reduced or absent urobilinogen. Stercobilinogen is the compound that gives feces the color, so it's reduced in the intestine, and now you have pale or clay-colored stools. This shows the biliary tree. So you have the common hepatic duct, cystic duct, the gallbladder, the common bile duct, the pancreatic duct, and the hepatopancreatic ampulla vata. So we could in obstructive jaundice, the issue could be found anywhere here. Another diagram. So this is classification.
Faisal?
Give me a minute. I'm transferring the document to another screen.
All right.
I think as it's transferring.
Pardon?
As this Faisal is transferring,
Mm-hmm.
I think there's some few things that when he's done, he will let us know.
Okay.
Remember, majorly what we are discussing is more of obstructive or surgical jaundice. And these days is more of obstructive because there are forms of the other causes of obstructive jaundice that can be sorted out without surgery. So the word surgical jaundice is a bit slightly a bit kite. So what we prefer mainly is obstructive jaundice. And from the history, there are things that usually must point out. I can say the discussion is generally jaundice, but from history, there are things that usually must come out to show some element of obstruction. And, I don't know whether the urine color was mentioned, how the stool was mentioned. I didn't really very well. I don't even remember. I remember. Tell us if there were any issues that were picked. The stool and the urine. Any changes in terms of color. I can see these body itchiness, generalized body itchiness for 1 year.
Doc, I'm sorry, but if you could increase your volume a little bit.
I'm saying, are you getting me now?
Yes, that's better.
Yeah, there are things that usually comes out from history on obstructive jaundice, especially on the history of presenting complaint. And one of the things that must come out is the stool color, the urine color, the history of itchiness. That usually stands out to a diagnosis of obstructive jaundice, usually. So I don't know from his history where that came out clearly. Is Faisal in the group or is still transparent?
I think this is him trying to present.
Jaundice is really a very large topic, so I think we narrow down to obstructive jaundice so that we can really digest how to really differentiate in terms of diagnosis, in terms of approach from history and examination. So I think we narrow down majorly to obstructive jaundice. That will really save a lot of time. Because jaundice per se, we may not even finish. in a while. I think it's really quite long. But obstructive jaundice, we can really. So there are things in history that really usually points out to obstruction. In the period three, whether it's hepatic, whether it's in the cystic ducts, whether it's at the ampulla level. So we need to pick exactly where the obstruction is clinically. How do we differentiate in terms of history? What do we need to ask? How do we investigate, and a bit of apparatus?
I think while Faisal tries to present, the rest of the members or the participants can also forward their questions to Faisal or the doctor.
Hello, Ayan, you can hear me?
Not very clearly.
Okay, how about now?
That's a bit better, yeah.
Okay, so I just wanted to comment on the history. I
Yes.
think it captures the most important things about obstructive jaundice, as Doc has mentioned. I think we have a complaint, chief complaint of yellowness of the eyes, and I think pruritus or itchiness is also captured, and also abdominal swelling. I also had something about a right upper quadrant pain, which is not very specific, but I think it also supports a liver involvement. So I also saw somewhere being mentioned about dark urine, I'm not very sure, and pale stools. So I think I would say the history is a fair one, a good one. So maybe when we are done with the rest of the presentation, maybe I'll just appreciate if we can have a general now a review of how to really approach and differentiate an obstructive jaundice from any other jaundice in terms of the history, clinical examination, and maybe what are the investigations and how to actually diagnose them. Thank you, Dr. Ari.
Okay, can I continue? Or should we wait for a response?
No, you can just finish and then we go back to that.
Okay, yes. So the focus is on obstructive jaundice. This is a classification according to the location. So we can have luminal, mural or intrinsic, extramural. Luminal is gallstones, parasites, for example, ascariasis, cholangiocarcinomas, ampullary carcinomas, strictures, class skin tumor, sclerosing cholangitis, mural. Extramural, we can have carcinoma of the head of the pancreas, ampullary tumors, lymph nodes, and chronic pancreatitis. According to the origin of the obstructive jaundice, so if it was congenital, we can have biliary atresia, choledochal cysts, inflammatory, ascending cholangitis, and sclerosing cholangitis. Neoplastic, we can have carcinoma of the head of the pancreas, periampullary carcinoma, cholangiocarcinoma, Klatskin tumor, extrinsic lymph nodes, tumors, or Meniere's syndrome. Benjamin's classification is according to the severity. So we have complete obstruction, intermittent obstruction, chronic incomplete obstruction, or segmental obstruction. So the causes for complete tumors of the head of the pancreas, cholangiocarcinomas. Intermittent obstruction, we have choledochal cyst, duodenal diverticulum, intrabiliary parasites, chronic incomplete obstruction. You can have strictures of the CBD, stenosis biliary enteric anastomosis, chronic pancreatitis, stenosis of the sphincter of Oddi, segmental obstruction, and primary sclerosing cholangitis. This is just a definition of Meniere's syndrome, is impaction of the gallstone at the neck of the gallbladder or Hartmann's pouch, which leads to chronic inflammation and fibrosis, which leads to obstruction and erosion of the common bile ducts. Examinations, lab examinations, we have complete blood count, LFTs, albumin, clotting, we have prothrombin time and all that. Imaging, ultrasound, MRCP, and ERCP. The management will obviously involve this, relieving the obstruction and other supportive care. So you can have cholecystectomies, resection of the tumor, Whipple's procedure, bypassing irresectable portion, supportive care, feeds, analgesics, and emetics, depending on the patient's situation. Okay. That's the part. We'll just go back to the history and see what the responses are. Okay. So the question was whether the significant symptoms of biliary involvement were right. Can you hear me?
Yes.
Okay, so there was she developed rashes, itchiness for a period of 1 year. The eye, pale stool, and dark urine. She also has a 5-year history of alcohol consumption, no cigarette smoking, no use of other drugs, no history of contraceptive use, no fever, chills, no previous contact with people with yellowing of the eyes, no previous history of hepatitis, no history of blood transfusion, no history of bruising or excessive bleeding, has not been recently managed for malaria, does not come from an area with large body of water, and does not eat grains stored in damp areas. The main symptoms brought her to the hospital was because she'd been referred from Nyeri for the cholangiocarcinoma that discovered there, and she was on follow-up since November last year. So she was admitted because of the swelling.
Oh, now the confusion comes out when you have a malignant cause of obstructive jaundice. What usually comes out, the jaundice is usually progressive, persistent, and usually pain is a later presentation in obstructive causes which are malignant in origin. Another factor is most of the times we usually bring out issues of weight loss. Has to come out very well. Whether in history of marked weight loss, especially in the history of presenting illness, I was expecting at least there was or in the summer at least it has to come out that where there was history of weight loss, especially, and then but other issues I can see very well. The issues of the itching was really very clear. The throat stool and the dark stool, and history of also cigarette use and alcohol. Because we are trying to rule out in the history, we are trying to see whether this was a benign or a malignant in origin as a cause of the obstruction in the biliary tree. But I can see it really came out very well. I don't know whether there is any history of weight loss in that patient.
Yes, there is a reported weight loss of 33 kgs.
33 kgs, yes.
That's good, that's great. So I usually point out so that when somebody is summarizing, what comes out clearly is this is an obstructive jaundice, and most likely the origin is malignancy. So usually on I can say the classification is quite wide. It's very much academic, but there are things which are very common. There are things which are very rare. So most of the times in practice for us, we just look at the congenital aspect of it. We look at the benign aspect of it, and when we look at the malignant aspect of it. So when I'm listening to history, what should come out clearly is that kind of where the obstruction really belongs. It's not congenital, then it's acquired. What usually comes out is that if it is not malignancy, it's very inflammatory. What comes out quickly is the pain aspect of it. But when it's malignant, what comes out from history is the yellowness of the eyes, the itching, the other factors, then pain being a later manifestation in malignant causes of obstructive jaundice.
Okay. Are there any questions?
The question I wish to ask, why do we get dark urine in obstructive jaundice? I think anyone can respond. Why we get dark urine when there's obstruction of the biliary tree? Anyone who can?
I think it's because of the increased levels in urobilinogen excretion in urine. When there's an obstruction to the biliary flow, I think there's a backflow of the bile into the bloodstream, which is then excreted through the kidney in large amounts, which now gives the dark colored urine.
Oh yeah, exactly. Usually we have conjugated bilirubin or the direct form in obstructive jaundice. And that one is usually water soluble. Therefore, that gives the dark urine, that discoloration of the urine. What of the pale stool? Why do we get pale stool or they call clay colored stool? What usually causes that?
I think anyone else can respond. We're having few participations. If you kindly have heard Dr. you can respond. Okay, Dr. for the purpose of time, I think I'll just respond. We've been told that stacobilinogen levels, it is stacobilinogen that actually gives feces the dark color. So when it is its excretion is reduced through the intestine, it leads to discoloration or what you call pale stools or clay-colored stools.
So what happens? The bile is usually produced in the liver. So what happens is when there is obstruction, let's say there's complete obstruction at the area of the cystic duct. That means there is no bile reaching the other part of the intestine. So there will be no stacobilinogen that will give the stool the normal color. Therefore, that's why there is that change of color. That's why it's pale. Most of the time they call it. Is that pale stool or and sometimes in malignant cases you can have some can have melena stool in the cases of malignancy. So why the stool is pale is that there is no bile, there is no stacobilinogen. So that is responsible for the normal discoloration of the stool. So that usually gives us the reason. What is the reasoning of the pruritus and why is it worse in the night? I don't know. Was it worse in the night in this patient? Or?
Yeah, she complained that the pain was worse at night. Yes.
Yes, yes. Usually it's worse in the night. And why? I don't know. Anyone can tell us why this first pruritus in obstructive jaundice? Why do you get that itching?
Did you ask about bile salts?
Why do we get pruritus, itching?
Oh, okay, yeah. Pruritus is because of the increased bile salts which are deposited in skin.
So what happens after that?
So
Usually what happens is when they are deposited in the peripheral nerve ending, there is production of some form of steroids and histamine. So the patients usually itch a lot, and is usually at peak in the night, usually high in the night and compared to the day. So most patients will tell you, I itch in the night, but in the day it's a bit fairer. So that gives you, on history, that gives you a very classical presentation of obstructive jaundice. There's that itchiness, but more worse in the night. And there's something I wanted to inquire about your history of the point of seeing why there's no constipation, no nausea, no vomiting, no hematemesis in this patient. So what usually happens is that when you have a patient who has cholangiocarcinoma, most of the times they spread to the stomach. So most of these patients we usually expect them. But the first thing they present is usually nausea, vomiting, features of compression effects on the stomach, and then the nearest thing you look at is the organs that are near the biliary tree that are usually affected. When you're looking at this review of system, the stomach being one of them, other organs. So I think classically when you go like that, usually it brings out very well. Because sometimes they have issues like gastric outlet obstruction, vomiting, and those things because of the cholangiocarcinoma, like in our patient. So you can see there was an element of constipation, there was nausea, vomiting in your history, loss of appetite, and weight of sediments. That has been great because it's usually very clear, and it's also you also need to bring out if there's history of cough. Sometimes there's meds, issues of meds, any bone pain. Just rule out if there are any instances of meds in this area where you rule out if there was constipation, if there was nausea, and we would really wish to know if there was meds to the chest, if there are any issues with the walking, if there was any other distance metastasis, any convulsion or renovation. So when we are doing that, when we are saying there is no history of this, means we are ruling out there were any history of, let's say, metastasis, for example, for this case, which is cholangiocarcinoma.
okay, okay. There's a question in the chat.
Yes.
Why do we really write yellowness of the eyes as a chief complaint in the HPI?
Where is?
yellowness of the eyes, as I've added in the HPI, is it supposed to be there as a, I mean, as a presenting complaint?
In fact, I think that's the first site where most people, that's the first mention where they say this yellow discoloration of the eyes is the first thing a patient tells you. And I think it will be okay. In the presenting complaints, if that's exactly what the patient tell you, I will not have any issues with that. If the patient tell you there is yellow discoloration of the eye, not the yellowness of the eye, but the yellow discoloration of the eye, I will definitely be, because the entire eye is not yellow, but yellow discoloration.
Okay.
It will really,
okay.
to make a lot of sense to me.
Okay. There's a request that you repeat the reason why pruritus is worse at night.
Yeah, it's because of that. Some school of thought believe that there is production of steroids. When there is that deposit of that bile salts in the peripheral nerve endings, there'll be production of histamine, there'll be production of steroids. And then, so there are some people who believe that the reason of steroids was in the night is because of the steroid aspect of it. It was in the night, and then in the day, but majorly, most other people believe that the histamine responsible for that. So there's no clear, exact explanation, but these are what most people think about the aftermath of the pruritus. And in terms of the day and night, most people really blame the steroid aspect of it.
Okay, are there any other questions?
Yes, there is. Somebody said, please comment on the Charcot's triad in obstructive jaundice.
Yes. Faisal?
I'm not sure. Can I get help with that?
The Charcot's triad, I mean, in the obstructive, I don't know what you're asking, in obstructive jaundice. But before that, I was asking, have you ever heard of Cavosia sign?
Yes, it's Cavosi's law is it states that in a situation where you have a swelling of the gallbladder and there is no pain associated with that swelling, it's not caused by a gallstone, but rather could be a malignancy.
You say this is palpable, let's say palpable gallbladder. When you have palpable gallbladder, usually it is less likely to be a benign cause, let's say a stone. And why do you think it's less likely to be a stone in the Cavosius law? Because what happens in a stone is likely to cause some element of inflammation. So the gallbladder will not have that the elasticity effect of the gallbladder or the biliary is lost. So there will be that swelling will be lost. So in malignancy, we just have an overt obstruction somewhere. That means bile is still being produced, so the gallbladder will be distended. So when you get in a patient who is jaundiced and the gallbladder is palpable, then that's where we call the gap. But there are exceptions to that rule. So it's not the exception. There are exceptions to that rule. There are some instances where that rule is a bit doesn't become true. So there are, but I think for learning purpose, it's good to know what the Cavosius law states. I think the person who asked the Charcot's triad is more of a biliary tree manifestation where there's right upper quadrant pain, there is hotness of the body, fever, and jaundice. That is What of Raynaud's? Have you ever heard of Raynaud's pattern? Lisa?
Yes, it's the three signs of Charcot-Strad plus altered mental state and was it neurological dysfunction?
Yeah, it's more of a complicated form now.
Shock, yes.
It's a sign showing ascending cholangitis. So it's more of upper quadrant 3. The 3 you have said with shock and altered mental state is called the Raynaud's pattern. So it's more of a complication of what we have really discussed. So that one brings out the Raynaud's pattern.
Okay, somebody, the same person is also asking if you could expound on the Murphy's sign.
Faisal?
Okay, Murphy's sign is it's an examination technique where you try to palpate for the gallbladder. You tell the patient to exhale and then inhale deeply. And when if the gallbladder is inflamed, they will gasp in pain, and it will be positive.
And usually, by the way, we have there are 2 forms of Murphy's sign. We have when you elicit the Murphy's sign with your hand, and they also sonographers, they also do sonographic Murphy's sign. So when they are doing ultrasound, we usually get what we call sonographic Murphy's sign. And that usually has a very high specificity compared to the palpable form of the tenderness. So usually some good sonographers will tell you the patient had a sonographic Murphy's sign. So they are putting their prop there. Usually patients jump a lot. Most people blame that it is as a result of an inflamed gallbladder. So when you get that, that usually rules out a malignant cause of the obstructive jaundice. So most likely the benign cause. Has anyone ever heard of calculus cholecystitis?
Beg your pardon, you said a calculus cholecystitis?
Yes, a calculus cholecystitis.
Yes, doc. It's a cholecystitis that comes as a result of anything other than, I think, gallstones.
And which patients do you usually see?
Pardon?
Which patients do you usually get in a calculus cholecystitis? Which kind of patient is very common with a calculus cholecystitis?
I would say probably, sorry. Someone wanted to respond? Okay. So primary patients with the ascending cholangitis, maybe? Primary ascending cholangitis? I think so, I'm not very sure.
Najma says severe ill patients.
Severe?
Ill patients.
Yeah, exactly. A calculus cholecystitis is very common in patients who have severe patients in ICU. Most of the time we get the patients who are very sick, patients who have severe trauma, burn patients, very common in patients who are in ICU. It's because of the body response to that trauma, causing stasis of bile. So the patients will get what we call a calculus cholecystitis. And then what did you mention in the investigations? What did you tell this patient? What do we do for this patient? Did I hear you mention ARCP or MRCP?
I mentioned both. Didn't know the difference.
Yeah.
But this patient had ERCP.
What is the difference in terms of ARCP, MRCP? Anyone who can try?
I can give it a try. I think both are used to image the biliary tract and up to the point where they also join the pancreatic duct. So by definition, ERCP is endoscopic retrograde cholangiopancreatography. I hope I'm saying it right. And MRCP is magnetic retrograde cholangiopancreatography. The one is endoscopic, where they use endoscopy to view the biliary tract and check whether there is any obstruction at the ampulla of vata, and they inject, I think, a barium liquid. For the MRCP, they use MRI to look at the biliary tract as in the case of obstructive jaundice and maybe other causes of biliary obstruction.
Yeah, they are both used to diagnose problems with the bile and pancreatic duct, whereas ERCP is more invasive and is both diagnostic and therapeutic. So with the ERCP, you can do ERCP, you diagnose there is a stricture and you still put a stent. You can do ERCP, you diagnose there is a stone and you still remove. But MRCP is more of diagnostic. We cannot use a therapeutic aspect of it like the ERCP. So ERCP has both diagnostic and therapeutic value compared to MRCP. So MRCP is non-invasive, ERCP is invasive. But the advantage is that you can do the intervention and still diagnose. So the major difference of ERCP in terms of advantages, one is non-invasive, one is invasive, one is therapeutic, one is not. So there are also range of complications involved when doing either of them.
There's one last question here. Somebody's asking for the indications of Whipple's procedure.
The indications of
Whipple's procedure.
Whipple's procedure. I think there are quite a number of reasons why Whipple's procedure is done. One of the commonest reasons why Whipple's is done is cancer of the head of the pancreas. Is one of the commonest reasons as to why Whipple's is usually done. And it's a surgery that involves removal of the head, part of the bile ducts, the duodenum, the gallbladder, and you do bypasses, like a triple bypass. So the commonest reasons I have participated in that surgery was more of cancer of the head of the pancreas. But it has a very poor outcome. most patients really, outcome is not very good. Mortality is a bit high, wherever it's usually done.
Thank you. I don't think there are any more questions, unless somebody else has any other question they'd like to ask. Or Doc, you yourself, do you have any questions for us?
I think he has really explained a bit well, in my opinion, with respect to obstructive jaundice. But from history, from examination with that patient, everything has been very, very much clear. But one thing with the LFT, what we said with the liver function test, those patients usually have increased direct and whether we can do an endoscopic ultrasound for those patients sometimes. The only problem with ultrasound is sometimes you may not see the stone because the air within the duodenum usually hides the stone in the biliary duct. So that makes the endoscopic ultrasound a bit less reliable. But it's one of the tools that we usually do when it has some diagnostic value. We can also do percutaneous transhepatic angiography. It's one of the things that's also done in patients for obstructive jaundice. Have you ever heard of stenting? Anyone who knows stent in obstructive jaundice? Remember?
Someone says stenting is placing a small pipe into the duct to allow for the drainage of bile.
And what are the indications of putting a stent? Those are the things we usually ask. Yeah, obstruction. Yeah, when we have strictures, commonly when we have strictures, patients who have strictures, usually that's where most of the times we put a stent. And also those with the malignancies, we also refer to put a stent. So there are different types of the stents that we usually use for patients. But the indication most of the times is when we have
Okay, so I think those are all the questions. So we can end the session. Thank you everyone for attending. And the next sessions will be communicated. سبحانك اللهم وبحمدك نشهد أن لا إله إلا أنت نستغفرك ونتوب إليك.
Thank you, Dr.
welcome.
Thank you, Faisal, for presentation too.
Thank you.